It is my privilege to introduce yet again another chief resident coming to not quite the end of her time here at UC Davis, as a matter of fact. Melissa Grigsby, who is our upcoming Grand Round speaker, hails from Westchester, Pennsylvania, where she grew up, and then went on to Swarthmore College before going back ultimately to Geisinger for her medical school. In the interim time, she had a serious bout, I don't know if that's the right word, as a basketball coach, both women's and men's, as I recall, and really, I think, seriously considered a career, what a path as a professional basketball coach might look like. I can just let you know that not only do we no longer have kickball tournaments here at the University of California Davis Surgery, but we probably aren't going to be playing basketball either with ringers like this in the crowd, at least not faculty versus residents. She then came to us we were privileged to match her here at UC Davis, and I think was a little bit not sure exactly what she wanted to do when she started, but between her time on the trauma acute care surgery service and spending time in the Green Hall lab studying determinants of shock and many of the other sort of profound issues that Dr. Greenhall and his group have looked at for a long time, she decided to go into trauma acute care surgery and is doing her critical care trauma fellowship here with us shortly, as a matter of fact. So with that, and you can see that she's been inspired a tad by Dr. Jerkovich, by the title of her Grand Rounds, and with that I want to bring and introduce Dr. Melissa Grigsby.
Good morning, and thanks, Dr. Farmer, for the kind introduction. It's an honor and a privilege albeit one that's assigned, to give Grand Rounds as a chief resident. So kudos to all the chiefs in my class and those who have come before me, who have given interesting and inspiring talks on topics from wine and laughter and skydiving to the medical uses of marijuana, the opiate crisis, and various topics in surgical history. Choosing a topic was a challenging prospect, as I don't really consider myself to be an expert on any particular topic, except maybe breweries in Northern California, but I didn't think that would really be appropriate. So I chose something that combines a bit of my background as an athlete and a basketball coach with my current pursuits in surgery. So today I'm going to discuss getting comfortable being uncomfortable. And to do so, I will explore performance anxiety, how it relates to surgery, and some strategies to overcome it, thus improving both training and performance. Dr. Jerkovich recently gave the Scudder Oration on Trauma, the pinnacle lectureship for trauma in the American College of Surgeons, and his title was, "I'm Not Comfortable with This." During his talk, he suggested that the phrase used to explain lack of ability, knowledge, or training, but has since become a shield against all that is unwanted, difficult, unpleasant, or just inconvenient. It allows physicians to absolve themselves from responsibility, in addition to handcuffing risk-taking innovation. And why has this become so frequently heard in medicine today? He offered several possible answers: perfectionism, fear of making an error, succumbing to the demands of patients, the increasing number of specialists, and possibly the current training environment. But what does it actually mean to be comfortable? Merriam-Webster offers several definitions: affording or enjoying contentment and security, the state of being free from vexation or doubt, the state of being free from stress or tension. I would imagine that if I asked you to raise your hand in the crowd if you are truly comfortable based on these definitions at your job every day, no hands would go up in the room. Medicine is uncomfortable. Surgery is uncomfortable. It is messy, it's challenging, and it is seldom perfect. For me, and for a lot of you, I'm sure that's part of the joy of the field. The chase, the puzzle, the thrill, and the reward. So when did we become so uncomfortable being uncomfortable? Before we delve into that question further, and I'm sure a lot of you have some answers sort of mulling around in your mind already, I would like to take a minute to tell you what this talk is not going to be. This is not going to be a discussion about resident autonomy. This is not going to be a hot take or a review of the most recent data regarding resident work hours. We're not going to review the literature on the surgical skills and abilities and opinions of fellowship directors of new graduates in the operating room. And it is not going to be a commentary on millennials, or any other generation for that matter, and how they fit into the current paradigm of surgical training. I would suggest that we have always been uncomfortable, but the demand for perfection in every aspect of patient care, now valued in terms of reported outcomes, career advancement, and reimbursement, has created a crisis of confidence and high levels of performance anxiety. Performance anxiety is a well-known, recognized, and researched entity in the realms of music and theater and athletics. During the pandemic, athletes in particular became much more outspoken about anxiety and stress related to competition. Kevin Love, Naomi Osaka, Michael Phelps, all athletes at the pinnacle of their sport have brought performance anxiety and discussions about coping strategies, both positive and negative, into the limelight. Various sources have offered some definitions of performance anxiety. Excessive stress and anxiety occurring in situations where a high-pressure task is performed, or the fear about one's ability to perform a task. These are often boiled down to stage fright. While there has been research into the stress, particularly the physical stress of being a surgeon and operating, the understanding of performance-related anxiety and impact on performance is sparse. So now that we've named the problem, let's proceed as Dr. Cantor would tell us to. Let's stage it. What is the extent of the problem? A recent article just in April in the Annals of Surgery from a group, Miller et al. Out of the UK, sought to establish the prevalence and potential impact of performance anxiety in surgery. They wrote that performance anxiety is a specific form of anxiety manifested during the performance of a task under a perceived or actual evaluation by others, and ranges from an exaggerated anxiety response to an incapacitating response and panic. Clearly, in its extremes, this has the potential to negatively affect surgical outcomes, just as it has been shown to negatively affect performance in professional musicians and athletes. So in their work, 523 surgeons, and this included residents and attendings, across multiple institutions in the UK, responded to a survey using the Performance Surgery Anxiety Inventory. And so this essentially, there's some survey tools that are well validated in performance anxiety related to music, and specifically. And they have adapted these tools to make them relevant for surgery. So they used that. They also used some survey instruments about well-being and traits, and then some free open text questions about surgical performance anxiety. Data was collected over 4 months, and interestingly was actually stopped prematurely due to COVID. That actually may have been kind of interesting, provided an interesting before and after, but ultimately they had enough respondents to power their study, and they were really just trying to get a baseline. So what did they find? Does performance anxiety affect surgeons? A resounding yes. 100% of those 523 respondents thought that performance anxiety affected surgeons, with 58% currently experiencing it. And about half of those responses were what they call consultants or attendings. So this is not isolated to those in training. Of those experiencing performance anxiety, 65% reported that it negatively impacted their surgical performance. It is worth noting that 70% thought there could be some positive effects as well, suggesting maybe there's a tipping point, a topic we'll explore a little bit later. But overall, this is evidence that performance anxiety affects surgeons of all levels and at a high rate. They went on to discuss that there was a significant correlation between surgical performance anxiety and low well-being scores, and furthermore, that global surgeon well-being scores were well below population norms. Anxiety and stress of surgery need to be normalized, researched, and addressed. This is an example of a survey assessment tool that was used in a different study. This is an earlier, smaller study, also out of the UK, and this was a tool that was used when a survey was sent to orthopedic and trauma surgery trainees. Similarly, it was kind of taken from one of these validated tools used in musical performance anxiety. So these tools and these surveys are somewhat limited because they're all self-reported scores about kind of people's general practice. But it's powerful to see these tools touching on the joy and the fulfillment when operating, in addition to kind of more classic signs of anxiety, worry, tachycardia, feeling nervous, hands shaking, that we often just attribute to excessive coffee, fatigue, or not eating that day. Okay, so we've defined performance anxiety. We have showed that it does affect surgeons of all levels and suggested that it can lead to lower well-being. There are a lot of things in medicine that negatively affect providers, but to really get the attention of those who affect change, we need to show that performance anxiety can affect surgical performance and thus outcomes. This is hard. Performance anxiety has not been studied much in general. Surgeons are not likely willing to report it when discussed in the context of outcomes and performance, and measurements would be pretty hard to control. But there have been some studies exploring the stress-related aspects of surgery. They have showed that fatigue, excessive noise, time pressure, and negative coping strategies decrease performance on specific laparoscopic tasks in simulated environments. There's one study from 2010, also out of the Annals of Surgery, from another group that has done a lot of work regarding stress and coping in surgery that I thought was particularly interesting. In this study, Wetzel and his group took 30 surgeons of all skill levels. They ranged from 2 to 34 years of experience. They had to have a minimum of 6 months of vascular experience, and they put them in a high-fidelity simulation of a carotid endarterectomy. They had a simulated full operating room. They had an actor as a patient. You had scrub techs. You have your nurses. Like everything is simulated. Each surgeon then completed 2 operations. One, a non-crisis scenario in which the operation was uneventful, and a second in which the patient had a series of crises: bradycardia on manipulation of the carotid body, stroke 3 minutes after clamp application, and a stroke on shunt removal. Stress levels were then measured by personal recall, again using kind of a survey instrument, an observer rating by the surgical assistant who rated how anxious they felt like you were during the operation, heart rate variability, salivary cortisol, and then there was also a standard assessment of surgical and technical skills by an expert in the field. In both simulations, the surgical endpoint was negatively influenced by higher self-assessed stress levels and less usage of coping strategies. Coping strategies, interestingly, did not correlate with decreased self-reported stress levels, but did correlate with worse surgical performance. Coping skills were, however, also independent from experience, and this suggests that these are not automatically gained with clinical practice. So to answer the question, it's complicated and it's messy to parse out, but if we extrapolate from some of these studies related to stress and coping in surgery, surgical performance anxiety likely affects surgical performance and thus patient outcomes. So what do we do about performance anxiety? We'll get to ways to overcome it or address it shortly, but first let's look at some of the triggers. These were also taken from that same survey study, particularly the open-ended questions. We got some themes from surgeons. So technical triggers, first, lack of experience, a high complexity case, a high risk case, whether that's relating to the factors of the case itself or the patient-related factors. Complications, maybe this is something that happens like they discussed during a stroke identified during a carotid, or related to complications that you've had before doing this same case. Environmental triggers included new equipment, unfamiliarity with equipment, or equipment issues, the overall environment in the OR, time constraints or efficiency expectations. At Kaiser, you have to identify if you're 1 minute late to the OR and why. The team, your rapport with them, their skill level in the case that you're about to perform. Other triggers included being watched or evaluated, personal factors such as family pressures or other stressors outside of the workplace, and colleagues, both within and outside of the specialty. So some direct examples of triggers from the paper that I thought were poignant. One was I lost my confidence coming back from maternity leave, and my colleagues were critical and unsupportive. Another surgeon commented that when doing a difficult but critically important procedure, I worried that maybe one of my colleagues could do it better than me. Somebody else said during decision-making during an emergency out of hours, and that being questioned during the light of day. These are all triggers for surgical performance anxiety. So I'm sure everyone has experienced some of those triggers. Maybe for you it doesn't lead you to performance anxiety, or if it does, it may not manifest in the negative, debilitating effects that it can have. This is the Yerkes-Dodson curve. It shows the empirical relationship between pressure and performance developed by psychologists Yerkes and Dodson in 1908. And this curve is based on a law that says that performance increases with physiologic or mental arousal, but only up to a certain point. When levels become too high, performance actually decreases. This is a tipping point that was suggested earlier in the 70% of survey respondents who thought that maybe there could be some positive effects of performance anxiety. So maybe a better question is, how do we avoid the negative effects of performance anxiety? How do you avoid getting over that tipping point? One answer, take yourself out of the situation completely. But assuming you all want to continue operating, training, and taking care of patients, the better answer is to build confidence and develop robust coping strategies so you can get comfortable being uncomfortable. For those of you who don't know me, I've been involved in team sports my entire life. My dad loves to tell a story of him taking me into the backyard to teach me how to throw a football. He handed me the football, he backed up, and then I just threw him a perfect spiral. And so that was that. The writing was kind of on the wall there. Soccer was my first endeavor and my first love, but I tried everything. Soccer, basketball, lacrosse, tennis, t-ball, roller hockey, everything. I played soccer, basketball, and lacrosse through high school, and then was able to continue playing lacrosse and basketball through my time at Swarthmore College. Ultimately, and I'm sure a bit to my parents' chagrin, I chose to pursue college coaching as a career after college. And, this was fitting. I had just completed all my pre-med requirements. I'd taken the MCAT, fitting for preparation for coaching. So you can see at the top right, that's my team at Swarthmore, my basketball team, and then my lacrosse team down here. And up in the top, other top corner, that's me coaching, trying to keep our players on the bench after a game-winning three-pointer with a little, less than 1 second left on the clock. And then obviously, perfect form developed as a young child playing soccer. So I pivoted back to medicine at some point, and my parents can now rest assured that my Swarthmore degree really did come in handy. My experience as a coach and an athlete has given me a unique perspective, and I think a real advantage in my surgical training. Although the following coping strategies will be discussed in terms of surgery, many of them I learned through my experiences in athletics. I hope that everyone listening today, from NPs to residents to chiefs and both junior and senior attendings, can learn a new way of coping or helping others cope with the stress of surgery and surgical performance anxiety. First, practice. Yes, we're talking about practice. Allen Iverson was one of the best scoring point guards to ever play in the NBA. I realize I may be dating myself to the residents who may not actually know who Allen Iverson is. But he was crucified in the media for being dismissive of skipping practice. But certainly he spent countless hours honing his craft. You may not think of practice as a coping mechanism, but it is described as anticipatory or proactive coping. Practice is your chance to fail without consequences. Practice is important for patient care scenarios, both inside and outside of the operating room, and can come in many forms. Being on stage for mock orals, ATLS, being pimped on rounds or in morning report, practicing skills in the skills lab. I remember vividly getting pimped about sigmoid volvulus intern year when we were crammed into the little workroom on Davis 11 for morning report. I'm sitting in the back, and the front table was reserved for the attendings and the chiefs, and I'm getting pimped in the back. I answered a question about OR timing after sigmoid volvulus. Dr. Kokenauer is walking into the room with the trauma phone, and she heard my answer, and she walks in and goes and sits down, and she doesn't even look at me, and I just hear, wrong. We then talked about it. I went home and read about it, and I have never forgotten the management. It's okay to fail in practice. In fact, it's encouraged, because this is how you learn. The most important aspect, though, of practice is repetition. You simply must put in the time. Repetition has also been shown to be key in adult learning and in skill acquisition and mastery. A study from the University of Toronto, published in Annals in 2006, showed that distributed learning in sequenced sessions is more effective when compared to a longer single learning session. Dr. Ho teaches us that when you're sewing the inner layer of your bowel anastomosis, when you think you are ready to transition to the canal stitch, throw 2 more. When you think you have mastered something, do 2 more. Get creative in your practice. Not every scenario has to be as ideal as a 3D printed skull and full operating room team practice session. When I was starting on transplant, I would make blood vessels out of clear plastic tape in the call room to practice sewing anastomoses. High-fidelity simulations certainly have their advantages, as does rehearsal with new equipment, be it simply a new stapler or a complex robotic system. With all the people involved, get them all together, go over these things. It's important and can potentially identify hiccups that can be avoided at game time. Find a coach, because practicing the skill the wrong way over and over is not useful. It helps you get really, really good at doing something wrong. Get tips and learn how to do things properly. I challenge the senior residents and especially the faculty to spend more time teaching and coaching technical and non-technical skills. Show a technique for a suture ligature and follow up the progress. Watch someone conduct an abdominal exam. Be in the room when somebody is having a goals of care discussion, and coach them on ways to improve. Junior residents, you aren't off the hook. If these things aren't happening, ask, show enthusiasm, follow through, or call Dr. Pierce. Ultimately, there is no substitute for the operating room and real patients, so find yourself there as often as possible. Stalk the OR board when you're on call. Ask 5513 to page you if they're going to the OR. Be more like Dr. Anderson and just keep showing up. No case is too small, no case is too simple. Sean Judge told me when I was starting on trauma, no one ever died from not having a note. Obviously, get your work done, but get to the OR and be a sponge whenever you can. The 6 or 7 Ps. Proper planning and preparation prevents piss-poor performance. I spent many hours preparing scouting reports in my days as a coach, watching endless hours of film and traveling to see other teams so I could prepare my team and give them the best chance to win. This included tendencies, strengths and weaknesses of other players, how we were going to exploit and guard them, our game plan, and how we should defend against the other team's strengths and plays. Preparing for surgery is not much different. You can decrease performance anxiety and gives you and your patient the best chance at a good outcome. Know the patient, their history, exam, imaging, and indication for the operation. Go over indications and imaging with senior residents and attendings. Know the operation, the anatomy, the steps, the equipment, the anticipated pitfalls. Initially, just knowing the key steps is important, but as you progress, think about everything. The positioning, the type of anesthesia, how you want to drape, how you want to enter the abdomen, which ports are you going to use, where are you going to put them, why are you going to use them, steps of the dissection, what type of mesh you're going to use. Think about everything. Autonomy, as we have learned, is harder and harder to come by these days, so consider practicing mental autonomy. Which instrument would I want next? Where would I direct the dissection next? What retractor adjustment would I make to improve exposure? Constantly be thinking as if you were in charge of the operation, even if you aren't. On the thoracic rotation, Dr. Brown asks the resident who is assigned to her case to email her with her operative plan several days before, and she responds with feedback in her plan. This is an excellent habit to get in. Draft an operative plan every time, even if it's not quite as formal as that. Talk to your attendings ahead of time, both about your operative plan and aspects of the case you would like to lead or to perform. Attendings, expect this, even demand it from the residents. When you have confidence that a resident is prepared and there is a clear plan for which skills are expected to be performed, both of you will likely have decreased performance anxiety. Don't stop there. Don't just prepare for operations. Plan for clinic, plan for rounds, plan for rotations. Dr. Hirose told me that morning rounds are more efficient when you have prepared at the end of the day or the night before, because you know what to expect and what things will be outliers when you see them in the morning. Excellent advice. If you've never been on thoracic surgery before, or you aren't comfortable with immunosuppressants prior to starting transplant, ask for resources and prepare. Also, get good sign out from your peers. Be prepared. Additional proactive coping strategies. Talk with your colleagues ahead of time. Are you going to need help reconstructing your IVC during a Whipple? Have you not done this complex case before, or you've only done few? Is this a challenging case and you just want someone who's more seasoned than you to kind of check on your operating plan? Do this early and often. Discuss tips, tricks, and line up backup when it's needed. Develop a consistent routine. This is not superstition. It makes things usual, mundane, and familiar. It lets you concentrate on other things that need your attention and keeps you from being overwhelmed. Basketball players have a specific routine every time they step to the free throw line for a reason. It's not a hard skill, but the game is stopped. All eyes are on you, and it's easy to psych yourself out. 3 dribbles, spin, catch, inhale, shoot, exhale. That was mine. Make a routine of the way you scrub, the way you gown, the way you drape, maybe the music you listen to, 90s alternative, or the way you set up your retractor system. Before every game starting in high school, and then before every major test, from OChem in college to the AB site this year, I have listened to World's Greatest by R. Kelly, for better or worse. Dr. Abramson asked the residents not to drape the patients because this is her time to get in the zone and transition to just thinking about this patient and this operation. If you can, develop a routine with your entire team and have a consistent OR team. Know each other's tendencies, what instruments you use for which part of the operation, how you like the needle loaded. Everything small that you can control, try to control it and develop a routine. Visualization. Sounds corny. Try it. The days before an operation, go over in your mind each step of the operation and the flow of the operation. Visualize you performing the surgery well and having a good outcome. Start with the patient wheeling into the room, the timeout, the prep, each step of the operation, your interaction with your team, you masterfully navigating a difficult part of the operation. This has a dual effect of case preparation and boosting confidence. Number 3, load the boat. Dr. Galante told us as interns, don't be the captain of a sinking ship. Use your resources. Your co-residents are your first go-to. Use those around you and ask for help when you need it. This does not absolve you of responsibility, but it should give you confidence to act. How many of us consider ourselves to have grown up on trauma or in the SICU, leaning heavily on the nurses, NPs, and RTs? How many of us rely on the experience of the transplant NPs and the thoracic PAs to think about consults differently, identify complications, or navigate their respective machines? Discuss tough cases, operative and non-operative, with your colleagues within and outside of your division. Remember your friends from medical school, your ED call buddy from the SICU? Some of you, the best colleagues are those outside of surgery. Don't be afraid to call your senior partners, and senior partners, don't make anyone afraid to call you. Mentorship is key. The most recurrent theme in these surveys that was discussed for change at the institutional level to overcome surgical performance anxiety was creating a more supportive environment and changing the surgical culture. I'm not suggesting that we lower our expectations. Mentors should maintain high expectations, and if you know me, I favor direct, honest communication and feedback. But it still can be done in a manner that fosters a supportive and team-based environment. Miller et al. In the performance anxiety study I've referenced included a survey tool that validated to identify perfectionism as a trait in the subject. Trait perfectionism was defined as exceedingly high expectations, exceedingly high standards, a propensity for overcritical evaluations, and disproportional negative reactions to mistakes. Sound familiar? Apply these tendencies to the OR, and you have surgical perfectionism. They found that there was a significant association between surgical performance anxiety and surgical perfectionism. Interestingly, surgical perfectionism was not significantly associated with age or years of experience, and there was no sex difference. It likely not only leads to performance anxiety in that surgeon, but also the trainees and everybody else in the room. Not all situations are under our control. We sometimes don't know the right answer, or that things will 100% turn out a specific way. That is uncomfortable. Imperfect patient care and imperfect surgery feels uncomfortable. However, patients often don't fit into neat boxes. Their disease processes are complicated. Their anatomy and physiology are unique to them. The circumstances of their lives and our lives are unpredictable. So trust your knowledge, use your resources, and say yes. Act, and have a plan of what to do if your plan doesn't go as expected. Galante often also harps that not acting in itself is a decision. You're still deciding not to do something. Complications and unexpecteds are going to happen. It is the nature of medicine and surgery. Be diligent in trying to avoid them, but when they occur, talk about them, improvise, and adapt, and ultimately learn. When you're going through hell, you have to keep moving. You cannot be paralyzed by fear or by being wrong. Number 5, be authentically and unapologetically you. I'm a woman, I'm a surgeon, I'm a wife, I'm a dog mom, I'm an athlete, and I am not often warm and fuzzy. You may laugh, but this is how in interviews I started the answer to the question of what is your leadership style. I think it was during third year when we started leading teams and becoming chiefs on our teams, when my wife told me that I should warn people about my personality because I can be intimidating. But if they saw me with my dog, they would probably know otherwise. So in my expectations talks at the beginning of rotations, I built in a disclaimer about the fact that I am not warm and fuzzy, and I do have high expectations. However, I have even higher expectations of myself. I will go to bat for any team member as long as they are honest and diligent, and no task is above me. I'm always willing to help. I recently did a session about leadership style with the mid-level and chief residents. We started by taking a personality test. Most people sort of laughed and giggled as they were going through, but most of the assessments were pretty spot on. We then discussed that while personality type may explain your tendencies and how you prefer to interact with, or your kind of default interaction is with the world, your behavior is always a choice. Self-awareness and knowing your leadership style, most importantly your perceived leadership style, is important for understanding your personal stress response. You may default to some unhealthy coping strategies. You may default to surgical perfectionism. One of the suggestions from the Myers-Briggs kind of packet was, for my specific personality type, was to not expect people on my team to go 100% all of the time. It is not always needed, healthy, or helpful. Similar to a training regimen, you can lift 65% of your max, or you can run at a slower than sprint, and these are useful and helpful. You may default to anger or panic. Knowing your tendencies and defaults allows you to recognize when you are going over the tipping point and how you can pivot or adjust. So know yourself. Be yourself, but consider adjusting your behavior when the situation calls for it. This again will help mitigate the negative effects of surgical performance anxiety of not just you, but of those around you. I worked for a basketball coach, Coach Potts. He would write a quotation on the board before every game. One pregame he wrote this: "If it is to be, it is up to me." This is going to be a list of intraoperative, technical and non-technical coping skills, and they are reliant solely on you in that moment. These can also really be applied to any patient care or high-stress situation. You get a 7911 page that comes in the first time you're taking 6100 call. You are carrying 5513 for the first time and get a 911 page to the medical ICU. So first, the stop and stand back technique. It's exactly what you imagine that it would be. Stop what you're doing, take a step back, and take a deep breath. It has two benefits. One, It allows you to release physical or muscular tension and relax. And 2, it gives you more time to gather yourself and think. And what you are about to do, about how you could do things differently, or about the next steps. In a particularly long reoperative neck case, Dr. Campbell told me to scrub out of the case. He and I both scrubbed out. He bought us both Snickers bars so that we could reset. Dr. Cook is known for scattering smoke and a Coke breaks during robotic esophagectomies for all of the staff members involved. Next, reassure your judgment. Summarize the scenario, either out loud or internally, and go over what has happened so far. Do you still land at the same place that you are right now? If yes, proceed. If not, improvise and adapt. Self-talk. Just talk yourself up. Focus. Maybe that means turning the music off, asking for the room to be quiet, or prioritizing tasks at hand. You're not being worrywart or negative Nancy or whatever you want to call it. If you want a quiet room, that helps you have a better patient outcome, just do it. Ergonomic adjustments. This can relieve physical tension, or again, simply buy you some time to think. Team communication. Load the boat in the room. Gather ideas if you are stuck. Allow anesthesia time to catch up if you've just gotten control of bleeding. Be clear with expectations about how the operation or situation should next proceed. Do things yourself. No resident wants to hear this one. But when a situation gets out of control or the pressure of the situation is turning into panic, sometimes you need to take over the task and do things yourself. Also, trust but verify major steps or key pieces of information. Number 6, debrief. Surgical performance anxiety doesn't necessarily stop once the operation is over or the patient is out of the hospital. Get in the habit of debriefing operations and patient situations. It does not have to just happen after a patient dies. It allows your mind to think about things systematically and have closure. It improves team morale and team function, which will serve to decrease performance anxiety in the future. It also can serve as resident feedback, which may decrease residents' own surgical performance anxiety. This is an example model from the Edinburgh Emergency Department. It takes 5 minutes. Unless someone is actively dying, you always have 5 minutes. At least 3 minutes you have. They are more effective when they are done hot or happen immediately after the event. Faculty, do this with your teams. Chiefs, do this with your teams. Include all involved parties, residents, nurses, medical students, NPs, scrub techs, anyone who is involved. And number 7, get a dog or 2. I'm kidding, sort of. Self-care is an important coping mechanism. Find time to step away from work. Don't let it consume you. Laugh, go outside, drink a beer, climb a mountain. This is me and my wife and Lindsay and Nicole after we had climbed Mount Lassen at sunset, you can see over there. Find time for the things and the people that you love. In conclusion, I hope you now have a better understanding of performance anxiety. My aim was to convince you that it affects surgeons, it affects quality of life and well-being of surgeons. It may also affect surgical performance, and there are ways to mitigate the negative effects through the development and use of coping strategies. Moving forward, some themes suggested in the literature for addressing surgical performance anxiety at the institutional level included recognizing an acknowledgement of performance anxiety as an entity, advancing research in this realm, and teaching surgical coping skills in a more formal manner. Please don't give us another online module to complete, however. A final prevalent intervention suggested was improving and coaching mentorship with a focus on professional environment. Dr. Elfenbein from UC Irvine published a systematic review that asked the question, have we created a crisis in confidence for general surgery residents? I promised that I would not discuss research or debate around the work hours or graduating chief skills in the OR. However, I would like to share a small part of his discussion. While it is not necessarily a bad thing to talk about positive aspects of what residency training used to mean, the reminiscing about the past often glosses over the negatives while coloring the present-day experience of being a surgical trainee. When we tell residents that their training is worse today than it has ever been, are we really surprised that they provide negative answers when we ask them about their confidence? I challenge everyone to continue to adapt to changes in training and the personalities, qualities, and traits of trainees. Build each other up instead of comparing each other to historical controls that can't be measured. Ultimately, we're not that far away from becoming your partners. Surgery is uncomfortable, but it's an amazing career, so get comfortable feeling uncomfortable. I would just like to take a minute to be thankful for the 6 years that I have spent here. I was a medical student rotating out here, and I got my first glimpse of what the camaraderie at UC Davis looked like from Jesse Bowman and Laura Galgansky. Dr. Holcroft then asked me directly during rounds what my step scores were. And I guess they were good enough for Doctors Galante and Farmer to take a chance on me. So thank you to everyone in the surgery department, and particularly the trauma division, who's believed in me, built confidence in me, taken the time to teach me, and ultimately helped to develop me into the surgeon I have become. Special thanks to Dr. Jerkovich, who has been an incredible mentor for the last 6 years, to Dr. Salcedo for continuing to adapt the residency program in an ever-changing climate, Drs. Calcutt and Kokenauer, who are giving me the opportunity to put the finishing touches on my training in the SICU next year. And thank you to the co-residents, my co-chiefs, and my OG class for picking me up when I needed it, laughing with me, sharing drinks, successes, failures, family, work, and everything in between. Thank you to my parents and family who have been supportive of this wild and crazy dream. And last but certainly not least, thank you to my wife, Michelle. We started dating when I was coaching basketball, just a few weeks before I got my medical school acceptance letter. She has never wavered. She's my biggest, most loyal support, and has truly made all of this possible.
Good move, putting the mask back on, just in terms of little habits. Dr. Grigsby, thank you for a fabulous presentation, and really, I think, reminding us what is the real joy in surgery and how to get there. It's not a coincidence that a lot of people are athletes, that athleticism is part of what attracts people to surgery. And it is a team sport. It's a combination of a team sport and fabulous personal performance. And I think your analogies were spectacular. I think many of the older surgeons, and I'm being really careful because now you've got me a little on eggshells about how to have this conversation, really lament the advent of the gel hand washing for the ORs. I mean, scrubbing is a whole lot more about preparation and mental preparation and the routines that people describe, as you well know, and just really a spectacular presentation. Glad we're going to have you on. We have a few minutes. Dr. Jerkovich.
Well, I have to rise and say a few words, Melissa. First of all, that was an incredibly mature presentation on the art and practice of surgery. First of all, I'm thrilled we're going to have the opportunity to work with you more in the coming year, because that understanding of what it takes to develop this privilege we have of being a surgeon was way beyond the number of years you spent in it. I'm quite impressed and amazed about it. The little tricks you offered, the techniques of focusing, the attention to detail, the planning, the looking ahead, the visionary stuff was simply outstanding in my mind. It was great. Second, I hope that maybe we can work together and get this wonderful presentation published in a manuscript of some type on how to help residents become comfortable with being uncomfortable, because that is the key. It reminds me a bit about this time of year, which is, Dr. Farmer mentioned it, a spectacular sporting time of year. Now, the sports I like are golfing and fly fishing and skiing as a personal hobby, but I'm not anywhere close to a professional athlete, or never was, like Melissa is. But this time of year provides the opportunity to watch performance anxiety play out on a very public stage. The NBA playoffs are prime examples of it. And a prime example of a coach who manages people, I think, is Steve Kerr of the Golden State Warriors. He is remarkably efficient at planning for games, looking ahead for the teams, working to their strengths and weaknesses, and all of his players, and even Steph Curry, will say that it's because of his ability to plan and look ahead, and et cetera. And for those of you who missed the Allen Iverson reference to practice, perhaps the more contemporary one of Ted Lasso, and his insistence on practice. It's practice. It's practice. And how valuable it was to the whole team, I think, is a modern example of it. So golfers, PGA playoff, the performance anxiety of making a mistake on the last set of rounds played out beautifully in the last playoff series. I mean, the examples are phenomenal for those of you who watch sports. And so it's a wonderful presentation, and I'm just thrilled to have you stay with us, Melissa. Thanks.
Hi. I just want to echo a lot of what Dr. Jerkovich said, that this was really amazing. It was really, I've known you've had a background as a coach, but it didn't shine until this morning, and I wish I'd known about it 6 years ago. While you were talking, and I don't want to get into the work hour stuff, because I've spent 7 years here, and I do think I'm well trained and ready for fellowship, but
So do we.
I just wanted to talk about a time when I was on service with Dr. Abramson, who corrected me sternly for not speaking with her about a case a couple days beforehand. And her point was that she feels that EMR creates a false sense of security among residents, that we understand the pathology, the decision-making, and sort of everything that she had put into the preparation of the case. And I knew the answers to her questions about the child. I knew the procedure. I'd looked at it, but I hadn't just connected with her. And really, that level of preparation has nothing to do with work hour restrictions. And it's a lot of like what Lisa Brown asks of us. And I guess, is that something that we could work in to improve some of this and to improve the practice patterns and being comfortable and the sort of attending resident relationship? And just what were your thoughts on that?
Yeah, absolutely. I think that it requires buy-in from both parties. It requires buy-in, Dr. Brown takes the time to respond to those emails, point out what in your operative plan is not in line with her operative plan. So it takes a bit of buy-in from kind of both parties. So I think it's definitely possible, and that's why I call the faculty to not just expect it from residents, but even demand it from residents. Not a big PowerPoint presentation, not tons of extra work, but just talking about what case you're going to do and what your plan is. It's so important. And I agree that EMR and just like technology in general has gotten away from us talking to each other, just drawing something on the board to really check your understanding ahead of time. And so really just finding time to and finding the confidence and courage to just go ask your attending, show up at their office, make a time with them to talk about it. And similarly, the faculty to kind of reach out and, some people do case conference where you go over the cases. That's, one way to sort of do that in a more formal manner as well.
It's interesting. My husband, as many of you know, is an anesthesia attending at UCSF, and their practice was every night before the case, the residents, after they did pre-op rounds, which of course, since no one's in the hospital anymore, doesn't happen, but they had to call the attending with whom they were doing the case the next day and go over the cases. It used to kind of drive me nuts. It was about the time I would get home, finally, from being a resident attending, and then his residents would call and they would, talk at the most inappropriate times in my mind for my world, right? But it was a requirement every single day, and it's just an interesting, different way of setting up the dialogue that is something to think about. As you say, it's a constantly adapting, changing residency program to the real world, and the EMR has influenced so many things more than I think we give it credit for. I think that's a great comment.
Thank you for your talk. As you might imagine, I can relate to much of it. I'm interested, you gave great advice about planning, and I couldn't agree more. stocking the chart, planning ahead as much as you possibly can. You've chosen a career where planning can be hard. So I'm interested in how you plan to approach your chosen career and how you might advise your trainees as you become an educator in this field about how to translate your advice for preparing so much to a specialty where a lot of what we do is react without having the opportunity to plan.
Yeah, so I think that, so clearly I enjoy being uncomfortable, and so that's why I've chosen trauma as my field. But I think while you can't necessarily prepare for every specific patient that walks in the door or operation in that moment, you have to just constantly be gathering data and experience and keeping yourself up to date. So you got to be Dr. Anderson. Find yourself in every OR at every opportunity to know, every little tiny exposure. You have to just show up in the trauma bay all the time. Next year I'm going to be spending 12 months in the ICU, but my face will be in the OR. It'll be down in the trauma bay constantly at every free moment to try to get those little kind of pieces of information. So even in a situation where you can't plan specifically for that particular patient, that particular instance, you just really have to lean on your experience and knowledge. And before walking into that experience, just really take a deep breath before you walk in. Dr. Greenhall used to say that you didn't burn the patient. So do your best to take care of them, but just really kind of lean on your experience and be confident.
Dr. Harris.
I thought that was excellent. I had a question after every slide, but I'm just going to go with one, which is in the spirit of the debrief, right? You've wrapped up your surgical training, at least your general surgery training, and so debrief us on what we did well or what are opportunities for improvement. And I would challenge you to give junior residents, those who are coming after you, and those who you will soon leave behind, us faculty, of how we can be better. Maybe one thing that we can do to focus on over the next year.
3 minutes.
For junior residents, someone told me to find every opportunity to be in the OR, and I really tried to do that, and I think that's the biggest thing is don't wait to get called, don't wait for a cool case, don't wait, just keep showing up, keep showing up, keep showing up. I think waited too long to realize that when you're in the operating room and when you're assisting, there's still a ton to learn. Every time Dr. Anderson moves the book Walter, figure out why he's doing that and what exposure he's getting or changing. There's always something to be learned. The way that somebody loads the needle in their needle holder, just be an absolute sponge and look and observe everything and take it all in. I think that's the biggest advice, even when you're not doing the operation. Like we talked about autonomy and be debated, but ultimately we just know that it's harder to come by these days. So you have to do the job of gaining that autonomy honestly, mentally in your mind. So I think that's my biggest advice for junior residents. And then for faculty, I think it's really kind of it's okay to have high expectations of residents. Okay, just because there's work hour restrictions or just because we're a quote different generation than you were used to, have high expectations. Okay, you're allowed to, and let them be known and in a supportive way, but still let them be known. From skills to patient care expectations, just have your expectations, that's fine. But make sure the residents know them, that they're clear, so that you can all kind of have an idea of what we want to get out of every day of residency, because it's a long 6 years, but it's a very short 6 years.
Dr. Salcedo, the closing.
Yes, thank you. I was trying to get the timing right. I don't have a question for you. I just wanted to kind of summarize a huge thank you for your leadership and your time here with us. I'm sure every single junior resident, every single classmate that you've ever crossed paths with is better for their interactions with you. As bereft of warm fuzziness as they may have been. I appreciate that every expectation your faculty has given you have met and exceeded. I appreciate your message to all of us that it's fine to have these aspirations, but none of it matters if you don't put in the time, and that you have led by example in that motto, putting in the hours and the time mentally, physically, and as you said so perfectly, just showing up. It's so much of what we do to learn and to develop. So I'm sure I can speak for all the faculty and everyone in the department. Thank you so much for your time here and all of your effort and all of your leadership and all the things that you have done to make this program better. I really can't capture that, how grateful we are for you.
And at the end of the day, we aspire to that greatness for the patient who's in front of us. Thank you again.